All set.
Fantastic. Welcome, everyone. Happy Monday, December 21st, and to our Grand Round lecture series. It is my pleasure to introduce Dr. Lynne Stevenson. She has been the Director of Cardiomyopathy and Heart Failure Programs at UCLA, Brigham and Women's Hospital, and currently is the Director of Cardiomyopathy at Vanderbilt University Medical Center. She's been an active member of AHA, ACC, ISHLT, and HFSA societies and contributed to 30 national guidelines related to heart failure, transplantation, ventricular assist devices, arrhythmia devices, decision-making, and advanced heart failure. She has served as a member of the FDA Cardio-Renal Panel and MedTech, and has an associate editor for Circulation Heart Failure, and is currently for JACC. She has played leadership roles at the NHLBI-sponsored studies for strategies of medical and device therapies in advanced heart failure, such as ESCAPE, REMATCH, REVIVAL, and the Heart Failure Network trials, and was one of the designers of the INTERMAX and NCDR-ICD registries, and collaborates in the Cardiothoracic Surgery Network. Her academic work reflects multiple aspects of heart failure physiology, clinical assessment, and patient-centered outcomes, and shared decision-making models. She co-chaired the recent ACC pathway document for heart failure hospitalizations and the ACC forum on incorporating patient-reported outcomes into practice. Strong commitments for her and are redefining heart failure with and without congestion, training clinicians to advance the science of personalized care, and seeking clarity and guidelines to encompass patient priorities for quality and length of life. Thank you so much for joining us today, Dr. Stevens, and I'll leave it up to you to continue. Dr. Stevenson, are you there?
She frozen? Dr. Stevenson?
I think, Dr. Stevenson, if you can hear us, your screen is frozen.
Give it another 5 minutes, you'll feel better, okay?
You can hear us. All right, well, we'll wait a minute. I'm sure her screen just the Zoom has been known to crash in these situations.
I'm back again.
Oh, and
Okay.
Zoom does that sometimes. So can you take the screen again? You have to share your slides again, please. Excellent.
Excellent.
You're up.
All right,
Thank you.
You can take away.
Thank you so much. It's a real privilege to be joining you this morning. I'm going to talk about redefining heart failure. I'm going to talk about taking congestion out of heart failure, low EF, about getting to dry during hospitalization, preventing readmissions for congestion, the journey of cardiomyopathy without congestion, and congestion and heart failure with preserved ejection fraction. When we started in cardiac transplantation, quick look because somehow I'm skipping alternate slides here. There we go. When I got involved in transplantation, it was back in the 80s, and we had many hopes for transplantation. And in fact, I compare it often to the space program. Very few people are ever going to walk on the moon, and yet many of those developments have contributed amazingly to our progress. And I think the breakfast cereal Tang is one of the examples. Cardiac transplantation is much the same in that very few people relatively will ever have a transplant, but it has attracted and concentrated heart failure patients at academic centers and taught us so much and contributed to much of the progress that's been made in heart failure. When we started in transplantation, this was our vision of heart failure. There was backward failure and forward failure. And backward failure, of course, are the symptoms of shortness of breath with exertion and supine, GI distress, peripheral edema. And those are the major symptoms of heart failure. But we were focusing mostly on forward failure in terms of our therapies. And it was thought that we had to compromise and allow backward failure in order to have enough cardiac output to perfuse patients. And this was the pre-transplant view of heart failure. If you look here, we had the classic curves, and this is from a famous textbook, implying that in normal heart failure, of course, you had to have increased filling pressures to about a wedge of 12 to get optimal stroke volume. In acute ischemia, you needed even higher pressures. So the assumption was that in heart failure, with dilated heart failure and long duration of disease, you had to have really high filling pressures, such that if you tried to get rid of the congestive symptoms, a low flow state. Turns out there was good news. And in fact, you did not need to have these high filling pressures. Much to the converse, it was actually an inverse Starling curve, so that the lower the filling pressures became, the better the stroke volume was. So this was the good news. We did not have to compromise and leave patients with these congestive symptoms in order to have a good cardiac output. Part of the reason for this, if you look at the heart that we're looking at, this heart on the left, this is not a Starling heart. This is a normal heart shown on the right. This is a heart removed at the time of transplant. And that heart is much enlarged, as you can see. And the usual Starling forces, in fact, while they may apply at the myocyte level, the overall heart functions much differently. And one of the major things is that this heart is about 3 to 4 times normal ventricular volume. And as the ventricle dilates, the mitral valve becomes incompetent. And David Adams has actually taught us a lot about how that mitral valve works. It turns out that the target of our therapies, with much of what we do to decrease filling pressures and decrease congestion, is to redistribute mitral regurgitation. This is a study done with nuclear imaging back in the 80s, showing that when a patient comes in,
I think we checked everything very carefully in the last period.
I'm sorry, I'm hearing someone else speaking. Are you hearing me okay?
We're hearing you okay. I had to mute someone.
Okay, that's fine. I just want to make sure it wasn't me. Okay, thank you. So this was the total stroke volume shown here, and with most of that flow going backwards, often about 70%. And when we decrease the filling pressures with vasodilators and diuretics, the total stroke volume decreases, but there's much less backward flow, as you can see here. And if we look at more modern studies done here with echocardiography, you can see that there is a marked reduction in the regurgitant volume from average 47 to 14 cc's with the decrease in the regurgitant orifice area. This was shown again actually in the ESCAPE trial. And this is without any inotropic therapy, just with vasodilators and diuretics. Mitral regurgitation, of course, remains a central target for reducing filling pressures in heart failure hospitalization, as shown here by the landmark study using the MitraClip, showing a marked reduction in hospitalizations for heart failure with the MitraClip to decrease this mitral regurgitation in a structural way. Much of the work done at UCLA and the Brigham, in fact, focused on trying to understand the impact of decreasing filling pressures. Certainly patients feel much better as soon as you get to a wedge pressure below 25. However, the outlook for them and their overall physiology is much better when filling pressures are further reduced to a target of about 16 to 18 millimeters, not only to decrease AV valve regurgitation, decrease the chamber size, decrease the natriuretic peptide levels, but actually just decreasing filling pressures decreases norepinephrine, endothelin. Increasing work from Canada has demonstrated that the sleep disordered breathing are markedly decreased when you decrease filling pressures, increased vascular flow reserve, increased peak oxygen consumption. It was clear for a long time that this was associated with fewer hospitalizations, and I think it's now finally become clear that the better survival that we see is not just a correlate of being able to reduce filling pressures, but that reduced filling pressures are actually a cause of better outcomes. So we clearly want to focus on taking the congestion out of heart failure, which is often possible to a major degree. When I started in this field, CHF stood for congestive heart failure, CHF. As it became clear that one could separate the congestion from the systolic dysfunction for many patients, we thought that this word congestive was somewhat misleading. And so we felt that that was no longer an appropriate term to describe everyone with heart failure. However, everything was abbreviated CHF, and it would have been very inconvenient, in fact, to change the words. So somewhere in the 90s, it suddenly became an abbreviation for chronic heart failure instead of for congestive heart failure. Let's talk now about getting to dry during hospitalization. These are the 4 hemodynamic profiles that we consider when we look at a patient who is hospitalized with heart failure. Asking 2 questions, is there congestion at rest and is there low perfusion at rest, allows us to identify patients in these profiles. And far and away, the most common profile is the warm and wet profile, in which there is congestion, but perfusion is adequate, although it may not be normal. In your hospital and mine, that's probably about 80% of heart failure hospitalizations. In the community, it's closer to 95% of heart failure hospitalizations, with the minority of patients actually having clinically significant hypoperfusion. This has now been incorporated when we talk about the twin goals of hospitalization for heart failure. And this is the ACC pathway document, which is meant to focus on the 2 goals and the fact that they are not simultaneous. The first thing that we want to do is to concentrate on the hemodynamic and decompensation, and to aim for stabilization by relief of congestion while maintaining adequate perfusion and blood pressure. And as we move towards that target, then we begin to look more at the long-term target, which is to work on optimizing guideline-directed care, shown here in green, and the overall optimization of outpatient care, which includes many aspects of heart failure management, shown in blue. But what we've recognized is that you cannot approach these simultaneously, that you have to relieve the congestion first in order to allow you to begin to optimize the guideline-directed medical therapy. One side point, which I think you can follow with some increasing interest, is that natriuresis may in fact be a better goal than net urine output. This was shown in our outpatient infusion unit at the Brigham, where the spot urine sodium after the first diuretic injection predicted what would happen. Similar data has come, in fact, from looking at the heart failure network trials and the importance of the initial sodium, and also from other data that's come out on the inpatients as well. And there's now a new NHLBI trial, which is being run out of Vanderbilt and Yale, looking at using a nurse-directed algorithm based on urine sodium output rather than on total volume. In terms of what we're trying to do, we're aiming to get to dry. So getting to dry, how do we do that? In general, what we aim for are the clinical parameters of getting rid of orthopnea, edema, getting a jugular venous pressure less than 8. And these are the escape criteria, which have become standard since then for the heart failure network trials, and for subsequent trials, the Everest and PROTECT trial. If we were, on the other hand, to measure hemodynamics, in general, our goals would be a wedge pressure less than 16, right atrial pressure less than 8, and a systolic blood pressure of at least 80 in the heart failure patients with reduced ejection fraction. I have to tell you, having moved now to Tennessee, this is increasingly challenging. I knew that there could be an issue as we have a patient population with more obesity, but what I hadn't realized at the time, that orthopnea, which used to be the sentinel symptom for many patients, in fact, is not helpful because so many people are using CPAP now. So it'd be interesting going forward how we're going to have our sentinel signs and symptoms with the growing obesity epidemic. One of the things we're recognizing is what we call the wash rate for wet and sent home. In large populations, this ranges between 25 and 50%. In the Everest trial, depending on how you define it, that's where we are. The 2-year mortality for WASH patients is 34% versus 22% in the Everest trial. In a very large European registry of almost 8,000 patients, there was a 31% WASH rate, again with a much higher mortality. In that group, the risk factors for being wet and sent home, by far the highest risk was moderate to severe TR, and at much lower risk was the patient with new heart failure versus the patient with worsening heart failure. We're going to talk a little more subsequently about the dominant role that right heart failure plays in these patients who are wet and sent home. We looked at two centers, academic center and a community center, and took a survey of clinicians as they sent their heart failure patients home, looking at what was the wash rate and why. The wash rate was about 25% in both the academic and community hospital. And overall, the primary reason was renal dysfunction, with other issues being patient resistance and noncompliance with diuresis and sodium and fluid restriction in the hospital, and multiple other reasons, but far and away the most common is renal dysfunction. That would be a lecture in itself, but I do want to comment just very briefly on it. The cardiorenal syndrome initially was felt to be pre-renal, meaning that people had been over-diuresed. Then it was changed to cardiorenal, and now I would suggest that perhaps a better term would actually be RV renal. It is equally common with heart failure with low EF and heart failure preserved ejection fraction. And far and away, the most common hemodynamic correlates as found in the European registry are tricuspid regurgitation and high right atrial pressures in multiple studies. This is a complicated graph, and I'm not going to go into it in detail, but this is from the PROTECT trial, looking at patients who had an increase in creatinine of at least 0.3 during their hospitalization for decongestion. And it turns out that although in the past that was associated with a worse outcome, it is only associated with a worse outcome if that creatinine increase is in a patient who did not go home decongested. So one of the reasons it has been such a problem is that often clinicians stop diuresing when the creatinine goes up by 0.3, and thus they send them home with the congestion that is clearly associated with worse outcomes. Now, one of the questions people ask often, and I cannot answer, is what level of creatinine is too much? And I wish I had the answer to that, but I don't. So going back to these twin goals of hospitalization, talk about relieving the congestion and beginning to coordinate our outpatient plans for diuretics and guideline-directed medical therapies. And it's critical to focus on this transition to oral therapies. We think that people have been discharged too soon, often right when the IV diuretics have been discharged, but many things need to happen between that time and the time that a patient is discharged. One of the things we are working on is the handoff before discharge, and that's part of what needs to be done on the discharge day. And the ACC Heart Failure Pathway has come up with this handoff document, which is being incorporated in various ways in different centers around the country into their EHR. The main things on this, first of all, is this patient wet and sent home? If so, why? So the clinician picking the patient up on the outside understands. What's the discharge diuretics and what's the rescue dose plan when if you have to increase? And for the GDMT, what of the recommended therapies are they on? And what has limited their titration, if anything? And what's the plan? So that there is a plan made before they go home. And we feel that this discharge handoff can markedly improve the outcomes of patients who have been discharged. It's really key at this point to maintain the benefits that you've started in the hospitalization. This is the only audience quiz here. Why we need a transition day. Which of these important tasks is best done on the day of discharge? Prescribe the first dose of a new heart failure medication? Probably not. Does the patient have time to learn about the reasons and schedule for medications? Probably not. Identify the provider who will supervise their management. It's too late by that last day. Or the last one, to make sure that your insurance will cover your new medications. Also, in general, too late. The main thing that happens on the day of discharge is to find the other shoe. So we really try hard on the transition day between stopping IV diuretics and sending someone home to address all the other important tasks that need to be done. So let me talk a little bit now about preventing admissions and readmissions, what we all talk a great deal about and many metrics measuring this. First thing is ADHF, which is a common phrase now for acute decompensated heart failure. It is not often acute, so that's kind of a misnomer. it's important to recognize that about 80% of patients admitted with heart failure have a prior history of heart failure. And in fact, over 50% of patients are readmitted within 6 months of discharge. Now, I'm not going to go into the multiple targets for neurohormonal inhibition in heart failure in this talk, but just to recognize that there are many ways that our neurohormonal therapies are effective in the remarkable improvement in outcomes that we've seen over the past 30 years, preventing remodeling, protecting renal function, decreasing apoptosis and ischemic events, affecting inflammation, and the hemodynamic benefits as well. Endpoints that have been used to initially demonstrate the impact of these trials have been deaths, which I would suggest is not really the best marker to use. I think it has been a biomarker, interestingly, for the benefit that has affected many people in heart failure. But what I want to focus on is heart failure hospitalizations as some of the evidence that these therapies have been effective. Let's think back. We talked about the decompensated patient. So let's think back about what takes them into the hospital. What takes them back in the hospital is the same thing that took them into the hospital the first time. It's largely this evidence of congestion. And for all these many trials that you read about, they've had these adjudication committees to adjudicate whether a hospitalization was really due to heart failure. How did they decide? They looked for signs and symptoms of congestion in the patient report and for treatment and response with IV diuretics. So although many things may contribute to heart failure hospitalizations, they are clearly episodes of congestion. So our therapies that reduce heart failure hospitalizations are, in different pathways, they are reducing congestion. So let's look at what's happened with our therapies, with the progressive reduction as we've added new therapies. With ACE inhibitors, the early trials, basically there was about a 28% decrease in hospitalizations. When we add on top of that, the beta blockers were already starting with a lower hospitalization rate, but we were then again able to reduce them by about 30%, although from a lower absolute number. And then when we add the mineralocorticoid antagonists on top of ACE inhibitors and beta blockers, there's yet a further reduction of about 30%. So each of these therapies has been very beneficial, but as you can see, the actual absolute number of hospitalizations has come down with each one. The reason I use emphasis rather than RALs is that that landmark trial actually was done before there was routine addition of beta blockers. And now we have the ARNI. Sacubitril valsartan now comes on the scene as well in the paradigm trial. And now we end up with yet a further reduction as shown here when we substitute the ARNI for the ACE inhibitor. But now we're dealing with really quite a small number of overall hospitalizations, although the percent reduction was highly significant. So if we put 21 patients on Entresto so if we take 100, we have to treat 21 patients with an ARNI for 27 months to prevent one death or heart failure hospitalization, because the cumulative benefit of our therapies to prevent hospitalizations has been so immense. Just one quick side point about sacubitril valsartan. This is a study done in patients who had the implanted hemodynamic monitor in, looking at the PA pressures at the time, the first 30 days. And you can see that for patients who started out with a PA mean pressure over 30, that there was about a 4 millimeter decrease in the average PA mean pressure over the 30 days after sacubitril valsartan. Those patients who started out with a lower PA mean pressure had very little impact, suggesting that in the patients who have high pulmonary pressures, that a major effect of sacubitril valsartan is actually to decrease those pulmonary pressures, which we feel in those patients contributes significantly to the benefit of this therapy. However, rehospitalizations may be reduced by ARNI, but they're not gone. This is the PIONEER trial looking at acute decompensated patients in the hospital, randomized to either sacubitril valsartan or to stay on or to be on enalapril. And regardless of which arm they were in, over the next 4 to 8 weeks, 50% of patients required an increase in diuretic dose of at least 50% at home. This obviously introduces a tremendous range of
Good,
decompensation.
Cokie. Come on.
So when we look at rehospitalizations, despite the use of our guideline-directed therapies, if we look overall, the heart failure hospitalization rates adjusted for age have actually decreased. The absolute numbers increasing as the population is increasing in age, but the rates per person have decreased. Readmission rates remain about 20% at 1 month and up to 50% at 6 months. We still have not seen the full impact of the ARNI and SGLT2 inhibitors, and it will take a while to see that. However, we still have a very high rate of hospitalization. So what's happening at home that we could address to decrease rehospitalizations? This is data from Anu Lala looking at the heart failure network trials from the NHLBI series. And in her data, she defined orthedema as significant orthopnea or edema. And you can see even in heart failure network trials with very, very vigilant centers that only 50% of patients achieved freedom from orthedema at the time of discharge. But even more important, of those 50% of patients who were free of orthedema at the time of discharge, by just 60 days, we already had a third of patients who once again had lots of orthopnea and edema, some who had little, and only a third of patients were free of orthopnea and edema after getting very vigilant therapy in the NIH heart failure centers. So clearly we have this problem of what happens after people have been decongested and go home. We know that it's not necessarily just that they're not calling their physician. This is nice data done by Maya Bargash when she was with us at the Brigham, looking at 218 admissions to the inpatient heart failure service. And of those, 2/3 had contacted their providers more than 3 days prior to admission and were still admitted. And it was a median of 7 days earlier. Of those patients who contacted their providers, the majority had a provider-initiated medication change, and yet they were still admitted. Although those who had had some intervention tended to have a lower BNP and a shorter length of stay when they were admitted than those who had no contact. But what this shows us is that early intervention is often not enough to prevent hospitalizations. And I think we haven't focused enough on this. When we get these calls, we're not sure when to intervene, but even more, we're not sure how much to intervene. And perhaps most critical, we don't have a way of determining if we have intervened sufficiently to prevent the heart failure hospitalization. The way we currently look at this now is very heavily influenced by data that we've gotten from the implantable hemodynamic monitor. These are 2 separate devices to do hemodynamic monitoring. This one measured the RV pressures. This one measured PA pressures. These are different patient populations, different trials. And this is what happened to the pressures prior to an event, as shown here at the peak of the pressure. You can see that these pressures began to increase almost 4 weeks prior to the event. Look now, different pressure, different population, different device, the remarkable similarity of this curve to what happens before an episode and then what happens after hospitalization. The striking similarity of these 2 curves is what really convinced me that we have found the physiologic truth here of what's happening once these patients go home from the hospital. It is not a sudden increase in fluid. It is not a sudden change. It is a slow accumulation of increasing pressures after discharge. If we use that information, one would hope that we would be able to impact these frequent rehospitalizations. And in fact, that's true. Once again, now I'm going to look at 2 different devices. This is a CardioMEMS device, and this is in the Champion trial. This is the laptop device, which measured left atrial pressures now. This is a device we won't see due to problems that come up with the atrial puncture, atrial septal puncture. However, if you look at the events when the patients are monitored, data is not used for management versus when it is, you can see a striking decrease in heart failure hospitalizations and almost the same type of decrease with this other device, perhaps even a wider decrease. And in this trial, patients were allowed to act on their own pressures after 3 months. So again, suggesting a remarkable consistency in the impact we can have when we measure these pressures. So why might there be a spiral of improvement where these curves actually continue to diverge over time? We think we're seeing significant behavioral remodeling. When patients find out that their pressures are high and that we're reducing their filling pressures by giving them more diuretics, we think that they remodel their behavior. We think there's reduction of ventricular atrial size, which we have shown, and that may contribute to a return of volume homeostasis, such that when there's a little bit of extra volume from a pizza or from skipping a couple doses of diuretics, that the heart may become better able to compensate for that if the filling pressures are usually maintained low. Patients have improved activity and confidence to plan for new events, and they become increasingly invested in their own care because they see how much of a difference it makes. So I think we see amazing patient empowerment. When we look now at the impact of these devices post-approval, comparing patients the year before implant to the year after implant, in 1,200 patients in the United States, we saw over 50% decrease in hospitalization during that year. And I would emphasize this is not control data, but this is actually all adjudicated hospitalizations before and after implant. And this is heart failure hospitalizations, but there's also quite a significant decrease in all-cause heart failure hospitalizations. And that's in part because other conditions such as lung disease are also favorably impacted by keeping lower filling pressures. We saw very similar done in Europe as well, with a very large decrease in hospitalizations when this was used after approval. Patients are compliant with therapies that make them feel better. Many of us who've gone through these other trials of telemonitoring with weights and symptoms and phone calls, by 6 months, generally fewer than 50% of patients are even bothering to transmit. And they reported little or no benefit on quality of life from those telemonitoring. However, using the hemodynamic monitoring to guide strategies, patients have a marked improvement in all aspects of their quality of life, as shown here, and this is shown at 6 months and 12 months, but it persists through 2 years, marked improvement in quality of life for both HFpEF and HFrEF. And if you look at their compliance, even by 2 years later, over 90% of patients are transmitting weekly with these pressures. And we think it's because they're aware of an improvement in their ability to control their disease. And looking at a specific score for that, the patients had a decreasing sense of their perception of illness over time with the PA pressure monitoring. So they feel like they have more control and less awareness related to their disease. So now if we look at progressive reduction in heart failure hospitalizations with our 3 current main therapies, and now we look at patients who are on those therapies, on the recommended therapies with the PA pressure monitoring, we have a 50% reduction in hospitalizations on top of the huge benefit of the neurohormonal antagonists. One quick side note on empagliflozin. At this point, this is a lovely small study done, randomized trial by Kosa Barad and his colleagues, randomizing patients to empagliflozin or to placebo and looking to see what happened over 13 weeks to pulmonary artery pressures. And you can see a significant and steady decline of about 2 millimeters of mercury in pulmonary artery pressures with the empagliflozin. So this may also contribute to some of these effects to decrease PA pressures. I'd like to point out to the younger physicians in the audience, this is a major trial. This is only 65 patients versus the Emperor Reduced, which is 3,700. The large trials are crucial to help us understand many things about the new therapies and to help generate new hypotheses, but you can come up with very important data from a small, cleverly conceived project. So I don't want you to feel that all the data has to come out of these mega trials with many, many people involved. Just a small group of people can answer very important questions if carefully focused. One of the other things I want to emphasize when we're talking about decongestion is the importance of the mitral valve. And David Adams has taught us much about this. This is looking at his approach to mitral valve surgery and how important it is to be thinking about the mitral valve. So before I leave the therapies that reduce congestion, I do want to acknowledge, in fact, that our devices are dramatically decreasing hospitalizations, as well as our medications. This is looking at cardiac resynchronization and what it did for death and heart failure hospitalization to reduce those. And this is, of course, looking again at the mitral clip. Just to remember that not only the medications, but our therapeutic devices are very, very important for this cumulative benefit in outcomes. So when we look at our medications and devices, we're seeing increasing effects to take the congestion out of heart failure. I'm just getting that one. So let's think about the big picture. Okay, if we look now at the progression of disease, patients have various things going on: hypertension, sodium sensitivity, obesity, liver disease, and we end up somehow with fluid retention, myocardial stiffness, vasoconstriction that cause congestion. And then as that progresses, we can end up with mitral regurgitation, and that may end up beginning to decrease forward cardiac output, even though initially we're only talking about congestion. Then as mitral regurgitation increases pulmonary pressures and you get pulmonary hypertension, you get increasing amounts of tricuspid regurgitation. We then move into the area of right heart failure, cardiorenal compromise, hepatosplanchnic congestion. There's activation of late stage inflammation. And all of these steps begin now to move us from the warm and wet into the cold and wet, where we're compromising forward flow. And this has been what the overall trajectory of heart failure has looked like for a long time. This right ventricle is the tipping point, and I now really focusing on trying to understand and prevent this right ventricular failure, we think will markedly improve the outcomes and the long-term trajectory with heart failure. We think one of the important things is to update our hemodynamic profiles and begin to start paying attention to not only is the patient congested, but are they congested on the right and the left proportionately, or is the right disproportionately affected, or the left, because our therapies need to change with this. And one of the things we have to learn as we look at patients is to begin distinguishing when the right ventricle is coming to dominate, because that in fact is pushing us towards end stage disease. If we look at patients with low ejection fraction, part of why RV function declines is facing the high pulmonary artery pressures. If you look at this graph, across the x-axis is mean pulmonary artery pressure. The y-axis is right ventricular ejection fraction. The higher those PA mean pressures go, the lower the right ventricular function. The impact of PA pressure-guided therapy, we think one of the major impacts will be to decrease pulmonary hypertension over time. If we look at the post-approval study, at 1 week after implant, the PA mean pressure was 34. At week 52, it was 30. These 4 millimeters of difference in PA mean pressure are incredibly important. If we look, for instance, at just defining pulmonary hypertension, the definition has changed to a PA mean pressure of less than 20. And one of the reasons for that is that if you look just at the difference between a PA mean of 20 to 24 compared to less than 20, there's a 30% higher mortality risk. So these small numbers of PA mean pressure are going to be very important for outcomes. So we've talked about how hopeful we are that we can decrease congestion and decrease the impact of congestion. So what is the disease going to look like? As we talk about these increasing interventions, all the different ways we have that we can prevent and relieve congestion, how is heart failure going to progress? What's it going to look like? I think we're going to be seeing evidence of the changes in the natural history. This is a lovely study from Denmark looking at a whole nationwide report of all the patients in the country This is looking at 20,000 patients who were less than 70 when they presented with their heart failure and had no other major comorbidity, were on ACE inhibitors and beta blockers by 4 months. And this is not the heart failure that we knew when I began. Their 5-year survival was 86%, but perhaps even more impressive, of the survivors, 78% had neither had a heart failure hospitalization nor even a diuretic increase in 5 years. So we are looking at the dawn of a different progression. So with less congestion in stable heart failure, how's it going to end, do you think? Are patients finally going to get cold and wet when the heart just can't pump enough fluid forward and begins to retain fluid because it has low output? Or is it going to end cold and dry? Are patients just going to become less and less perfused? Or are they going to end up with electrical storm? And I have to say, partly because we do a lot of ventricular VT ablations here, I'm seeing more and more patients who in fact have done quite well with a low ejection fraction for many years until they develop refractory ventricular arrhythmias. So what's it going to look like? It's going to be different as we go forward. Most ambulatory heart failure is now free of congestion. This is looking at about 1,000 of our ambulatory patients at the Brigham. And of those, 1% met any criteria for class 4 symptoms. This is totally different than when much of the research and much of the literature that you look at came from a time when class 4 was quite common in the outpatient setting. One of the things I'm most interested in is when we can decrease congestion, we may finally begin to better understand how cardiac disease progresses without this additional load of elevated filling pressures and congestion on the heart. So we may begin to finally understand better when we can take the congestion out. We finally begin to see how does the disease progress. I think it'll be particularly interesting for the genetic myocardial disease, for toxins of abuse, for chemotherapy, tachycardia-related cardiomyopathy. How is this disease going to progress? And what is the role of myocardial inflammation in the disease when we don't have so much congestion? So if heart failure doesn't progress through congestion until the late stages, how will we track early disease progression in this next era? If you don't have congestion, you won't be able to use heart failure hospitalizations until late in the disease. What about BNP levels? Although they do go up before there is clinical congestion, much of the high level elevation has been related directly to congestion. We're going to want to find which biomarkers are independent of congestion and which ones are just detecting early congestion. So we're going to want to look and understand better fibrosis, apoptosis, the energy deficits in the absence of this congestion that we've really used as our major marker of disease progression. A couple of comments on heart failure mid-range ejection fraction, which I would frankly almost like to forget because I think it's misleading us. I would say that heart failure mid-range ejection fraction, it's a crossing, not a country. You have someone who comes to you with an ejection fraction between 40 and 50%. You have to exclude, first of all, do they have a moderate sized MI that left them with that? That's not a different disease. That's just an intermediate stage. Amyloidosis, decompensating primary valve disease can present at this stage, other restrictive disease. Once you've excluded all those, the patients who are remaining are mostly what I call HFrEF in transit. They're heading down to a lower EF, or they're improving from a low EF to a better EF. And that's not really a different disease. It turns out there's an unexpectedly large proportion of recovered EF. This is from a study by Lynne and Akshay Desai. And she was actually assigned to study the echo differences between HFrEF and HFpEF. And she came to us and she said, what am I going to do with all the people in the middle? And we said, well, there aren't many of those. She said, no, there are a lot of those. And it turned out that a third of our clinic population was made up of patients who had had a low EF, who now had an EF over 40. And there have been really important studies done since that by many groups, particularly Tom Coppola's group, looking at this recovered EF and demonstrating it's not really recovered, it's just better. This is now looking at almost 1,000 patients in ambulatory heart failure clinic, looking at the current EF And this is focused now on this lavender group. This is the heart failure mid-range EF. So we took those patients, we said, where did they come from? And of those, the vast majority came from a history of a lower EF that was now a better EF. Quite a small number, in fact, had never been shown to have a lower ejection fraction. So I would suggest that we should think about the mid-range EF as, in general, specific diagnoses like amyloid or patients in transit. If you look at what happens to these, there are a couple of large registries that looked at it. And if they followed them for 2 years, 45% improved to an EF over 50, 22% fell to an EF less than 40, and only a third actually remained in this so-called mid-range. Now I want to address just a little bit the issue of heart failure with preserved EF. Many things are quite similar, the way they present, the way we treat them in hospital. Heart failure with preserved EF is rising quickly as a proportion of our hospitalizations. This showed from 2005 to 2020, the proportion of heart failure with preserved EF in the hospital is going up. Heart failure with low EF is going down, and part of that is the marked effectiveness of the therapies that we have for HFrEF now to decrease congestion, but not for HFrEF, not for HFpEF. Well, where's HFpEF most likely to come from? Hypertension, obesity, diabetes are certainly what we know best. And those can lead to HFrEF, but in fact, most of the hypertension that goes to HFrEF does so through the route of coronary disease and myocardial infarction and microvascular disease. Without that, most heart failure with hypertension, in fact, is heart failure with preserved ejection fraction. There's interesting data out of Mark Drasner's group at UT Southwestern and some of our group from our synthetic derivative at Vanderbilt, demonstrating that most of the heart failure from hypertension is HFpEF, except in those patients who have had a myocardial infarction intervening. Well, how do we prevent heart failure in people with hypertension? Consistently, diuretics are the most effective therapy to prevent hypertension from progressing to heart failure. And this has been shown now. This is a meta-analysis of almost 200,000 patients. Compared to placebo, diuretics decrease heart failure by 50%. 50%. Compared to ACE inhibitors, diuretics reduce more heart failure than ACE inhibitors in treatment for hypertension, more than ARBs, and more than beta blockers. So diuretics are the most effective way to prevent heart failure from hypertension, which, as I've indicated, most of that is heart failure with preserved EF. We're not really sure about the new SGLT2 inhibitors. In fact, there's surprisingly little data about what kind of heart failure we're preventing with the SGLT2 inhibitors. This is the only thing I could find, which is a research letter on canagliflozin, suggesting that it actually had more benefit to decrease HFrEF than HFpEF, but I think we're going to have to wait and find that. But we need that information in order to understand that therapy. Obesity. Obesity is a huge factor in HFpEF. If we look at the ERIC study, 10,000 patients in relation to their body mass index, basically defined as a risk of 1 is the heart failure with a normal body mass index. By the time you get to a BMI over 30, you see an increase in heart failure, mostly HFpEF compared to HFrEF. When we look at over 35, 3.5-fold increased incidence over the next 10 years of heart failure in patients who are obese. There is an increase in heart failure with reduced ejection fraction, but this actually goes away when you control for the other cardiovascular risk factors in this population. So obesity is causing HFpEF. HFpEF with obesity is wetter than HFpEF without obesity. This is nice work done by the Mayo Group, looking at their obese HFpEF, here higher body mass index and higher filling pressures at rest than those with the non-obese heart failure. I have to say, I think there's something different in Minnesota. I don't even know how I would find enough patients with HFpEF who don't have obesity to study, but their work has been very important. And additionally, one of the other interesting things, which I think we consistently see, is that the ratio of the right atrial filling pressures to left sided filling pressures is consistently higher in HFpEF with obesity than in HFpEF without obesity. Ambulatory PA pressure guided management is highly effective for HFpEF, and it is the only highly effective strategy to decrease hospitalizations in HFpEF. They are decreased by more than half, as shown here. This is from the randomized trial, the Champion trial in HFpEF specifically, heart failure hospitalizations without using hemodynamic monitoring and with for HFpEF. And this is a post-approval study. Again, a 60% decrease in hospitalizations for HFpEF. The BMI actually has quite a bit to do. This is work presented by Marshall Brinkley this year at the ACC and now in manuscript preparation. There is a greater relative risk reduction the higher your BMI is. Again, suggesting that there's something that is very amenable to PA pressure-guided intervention with diuretics in the obese population. And when he looked at his population, whether it was HFrEF or HFpEF, the patients who had a BMI over 35 consistently had about a 2 millimeter higher filling pressure than those in that EF group who did not have a BMI over 35. The other point I just want to raise is that we think about HFpEF as being a disease of a stiff heart. Isn't it interesting that consistently when we compare it to HFrEF, the filling pressures are actually slightly lower in HFpEF than in HFrEF? What about pulmonary pressures? We talked about heart failure with low EF, heart failure with preserved EF as well. The pulmonary pressures are very high determinants of right ventricular function. This is the PA mean pressure now, looking in heart failure with preserved ejection fraction. And the higher it gets, the lower the RV fractional shortening gets in patients who have HFpEF. Heart failure low EF and heart failure preserved EF, they share this congestion phenotype, but probably not the root causes of congestion because neurohormonal antagonists do not clearly decrease heart failure hospitalizations with preserved EF. Nothing like the magnitude with heart failure low EF, and we can discuss the degree to which they may decrease it to a small amount. But the ambulatory PA pressure-guided management, hugely effective for both. There are multiple axes of HFpEF phenotyping, with or without obesity, chronic kidney disease, fatty liver disease, diabetes. So I think it's not just one disease, and that's why it's so hard to come up with common therapies that would work for it, because I think there are many different diseases. I would point out with considerable alarm the rising role of non-alcoholic fatty liver disease in HFpEF. This kind of liver disease is present in 40 to 80% of adults with diabetes, 30 to 90% of adults with obesity. This is a study from Australia looking at heart failure hospitalization, in which half of their patients had non-alcoholic fatty liver disease, and those who had it had a much, much worse outcome just by 1 year in terms of their event-free survival. So this is something we need to understand and watch closely. So there are these multiple axes of heart failure with preserved ejection fraction, and one more interestingly added by a very interesting article in JACC this year demonstrating there's a decreased peripheral lymphatic capacity in HFpEF as well. So I would propose that for heart failure with preserved ejection fraction, the heart may not be at the center of this disease. It may be a bystander. So until the right heart fails, I think we might understand this disease better if we think about taking both the heart and the failure out and trying to figure out how the other organ systems and other conditions are contributing to heart failure, to the congestion of heart failure with preserved EF. Now, I just want to conclude demonstrating, we've talked a lot about heart failure and congestion as being fluid. I recognize elevated filling pressures are many things. It's not just about fluid retention. Things that cause vasoconstriction and shifts in vascular tone are clearly important. However, the efficacy of diuretic therapy to relieve and prevent congestion clearly suggests that fluid retention is a major part of this condition. And for those of you in the audience who are young and trying to change the world for heart failure, could you help us figure out why patients retain fluid? We now know it's clearly not because the cardiac output is necessarily going down. There are many reflex responses we just don't understand. So we need to understand why fluid first goes up before we can really address the problem of congestion and heart failure. So to conclude, I think we should focus on taking the congestion out of heart failure with low ejection fraction. In this era where we're quarantining and most of us are taking our food out, I want to focus on these take out lessons. Take the congestion out of heart failure with low EF. We want to get to dry in the hospital and watch for those wet and sent home patients because they're going to be back and we need to understand them better. How will cardiomyopathy progress without congestion? When we can keep the congestion out, I feel it may not progress so much, but when it does, it will be pathways that we can hopefully finally see better. Heart failure mid-range EF, it's a crossing, not a country. We don't want to focus on it specifically as a separate disease. And I think we may want to try to understand better what heart failure with preserved EF is by taking the heart failure out of it and call it congestion with preserved EF. So it's been a real privilege to join you this morning. And I hope that we are all heading into a grand new 2021. I think that the light at the end of the tunnel is shining from the end of a needle. Thank you so much.
People have been muted, so anyone who wants to join and ask questions, this is the time, please.
Yeah, hi, Lynn. This is Donna. So good to see you. I hope everything is going well down in Nashville. It was a beautiful talk. One thing that I would like to comment on is that I do think that congestion is important in heart failure because it's the key that causes symptoms. And, it's the key that brings patients into the hospital and into our offices. But I would urge everyone to remember that the real problem is the pump and that, our other guideline-directed medications are more effective than diuretics in trying to reverse the problems that are occurring in the myocytes. And I think that, if we got rid of congestion, we will have progressive heart failure because it's a pump problem and it's not just a fluid problem.
And I agree completely with you, Donna. I think that it will not progress as quickly or as dramatically without congestion because that clearly increases the stress on the weaker myocardium, the further dilatation. But I agree with you completely. And what I'm excited to start trying to understand is when we don't have the congestion, how does it progress and what other ways can we treat it? Because so much of our therapy and our markers of therapy have really just been looking at the consequences of congestion. So I agree with you completely. I think we're finally going to begin to understand better how the pump function deteriorates when we don't give it this added burden of congestion.
I think that for a heart failure preserved ejection fraction, the only thing we have is diuretics. And clearly, we treat congestion and we don't treat it adequately and the patients just get worse. Anu and Maya, you don't have questions for Lynn? Anu and Maya?
I'm just giving other people a chance. I think Dr. Fuster wanted to say something.
No. I just listening.
Well, hi, Lynn. It's so great to see you, albeit virtually. And thank you for everything that you have taught me. Anything, much of anything that I've done that's good is because of your training. So, and thanks for giving a shout out to Maya and me. I wanted to ask your opinion on two things, unrelated. One, what your sentiments are on the recent, buzz around the FDA approving spironolactone and Entresto in heart failure with preserved ejection fraction, despite the primary endpoints in those major trials being negative. And maybe I'll wait for you to answer that question first, and then I can ask my second one.
I don't disagree with it. I do think it may be a little misleading. And I'm hoping that people recognize that the impact that they may have on HFpEF is much, much smaller by orders of magnitude than it is in HFrEF. So I don't think they should expect the same benefits. And I think they should, and what I'm most concerned about, however, is this this discussion at the moment that heart failure may be a continuum from HFrEF to HFpEF as the same disease. And I think they're very, very different diseases. And if we start to think about them as a continuum of disease, I think we're going to miss a lot of really important basic physiology and clinical physiology.
Thank you for that. And then my second question, unrelated, more on the congestion note of things, is we've talked about this previously, and Jeff Testani has kind of blown our minds with this concept as well of what the role of sodium really means in trying to decongest and keep patients decongested, if you will. And I was wondering if you could comment on whether you've had any experience with giving patients saline, in fact, during episodes of decompensation, and then what your take is on general on sodium and heart failure.
Well, I think there's two separate questions there. One is, I think that when patients come in congested, that to focus on getting them to urinate out sodium is very important. I don't think there's much question about that. In terms of the net decrease, we have to decrease sodium and fluid to decongest them. The question of using hypertonic saline to overcome diuretic refractoriness is a different question. You know, it's hypertonic saline, very short, very focused. And I've had a little bit experience. I've not been very impressed with it yet, but I haven't really looked at it systematically. So certainly there was a fair amount of data that came from Italy that I think turned out to be to have some challenges to it. And I remain kind of open on that. We are working with Jeff on this study to have the sodium-based protocol to see how that works compared to just a urine volume-based protocol. One of the things that we have not really looked at, we don't understand even in hypertension, but I think we need to try to understand in both hypertension and heart failure, the degree to which some patients are very sensitive to sodium. Their blood pressure goes up, and in heart failure, they may be the people who can't eat sodium because they retain fluid, whereas other people do not. And right now, we may be being needlessly proscriptive by telling all heart failure patients they can't have sodium. So we need to begin understanding what sodium sensitivity means for heart failure as well as hypertension.
Thank you.
Lynne,
So good to see you.
Lynne, I think we will have to finish. You have always been a concept creative, and today you are not different. Continue like this. I really appreciate it. And it makes people to think. And I appreciate very much you took the time to be with us this morning. And on behalf of our group, warmest thanks to you.
Thank you. And I wish everyone a good holiday, but even more that 2021 brings us together again in person.
I hope so, Lynne. Thank you very much. Thanks. Thank you.
Thank you.